I'll share my screen by myself, right?
Yes, after I briefly introduce you, then I'll hand over to you.
So it's 3, 2, 1. We are live to the audience. Over to you, Charmi ma'am.
Good afternoon and very warm welcome. My name is Dr. Charmi Prajapati and I am part of medical affairs team at McLeod's Pharmaceutical. So as we all know that prevalence of diabetes is increasing worldwide and India has second highest diabetic population in the world followed by China. So in order to get deeper into the topic and to understand various aspects of diabetes management and particularly sulfonylurea, gimipiride, we have with us Dr. Abhilasha Jain as our esteemed speaker for the day. Ma'am is consultant and head of Department of Endocrinology at Amritdhara Hospital, Karnal. She has received numerous awards during her academic and has presented oral and post also part of social group named Aditi, Association of Diabetes in Young in Tri-City. It's an honor to have you, ma'am, and I hand over the session to you.
Thank you so much, Dr. Chami, for such a nice introduction. So today in this post-lunch session, in this small CME, I will mainly talk about how sulfonylureas are important even in today's practice, especially in India. And we know we are different from our Western counterparts in various forms. Our diabetes, it comes earlier, a decade earlier. The complications are more. The affordability, I think it is a very, very big issue because of all the new medications, SGLT2 inhibitors, DPP4 inhibitors, they are quite expensive. So they cannot really be given in the long run. It is very difficult for any patient to afford, especially in a country like ours. So how sulfonylureas are relevant in 2022 and especially in India. So that is what I'm going to talk about in the next 15-20 minutes of our talk. So I hope my slides are visible to all of you. So
Yes,
as Dr. Shami has really already pointed out, we Indians stand second all over the world if we count the prevalence of diabetes. So almost 1 in 7 of all the diabetics worldwide is Indian patient. So it is the second highest country with diabetes prevalence. Around 74 million diabetic patients are there in India. So huge number of diabetic patients in India. Definitely more complications are there in our Indian patients because of the poor educational status, poor affordability status. So again, complication rate is very, very high because of the prevalence itself and the affordability status. So what is there that with so many medications available with us in the market, huge number of diabetic and anti-diabetic medications in the armamentarium is there, but still we are lagging to, we are struggling to control diabetes in Indian patients. There are studies to show that only maybe around 17 to 20% of patients are actually having HbA1c less than 7% or less than 6.5%, the targeted HbA1c. Maximum 80% of the patients are having their HbA1c of more than 7%. So it means highly uncontrolled diabetes is there in India. So what are we missing? What are we doing wrong in that? So somehow in the last, we'll say around 4 to 5 years or 7 years or so. So we have been talking about newer generation medications a lot. So we try to give SGLT2 inhibitors, try to give DPP4 inhibitors, try to give other GLP-1 receptor analogs, costlier medications in which the adherence of the patient, the compliance of the patient might not be proper, might not be actually very good. So patients, the dropout rate is very, very high. So today, that is what I'm going to talk about, that we do have very good medication available with us, which is there for the last 50 years with us. And the misconceptions which are associated with that. are really misconceptions, and we are going to show some evidences regarding that, okay, that these are not really true. So one of the most important misconception is that it causes beta cell failure. So it is really not true. In fact, there are studies to show that. So this was a study which was published in 2010, where they have compared um, the over the 10 years, they have compared the level of C-peptide. They have compared the ratio of C-peptide and glucose. They have seen the HbA1c levels. And at the beginning of the study and in that cohort, by the end of the 10 years, they have again repeated the same test and saw what was the change in the beta cell function. So if we see here, over the time, HbA1c has increased. So we can see here the p-value was significant. The insulin at follow-up has decreased over the time. P-value was significant. Postprandial C-peptide value has decreased. So it means that a decrease. It means that beta cell deterioration is there over the long time. But if we see here, if the use, it was associated with the treatment of sulfonylurea, here we can see the p-value is not significant. So over the time, there is increase in HbA1c, which is associated with beta cell function. That is true, but it is not associated with use of sulfonylurea in the long term. So study findings do not support the notion that sulfonylurea as used in clinical practice is harmful to beta cell function. So poor glycemic control per se can lead to beta cell dysfunction, but sulfonylurea's associated use of sulfonylureas might not be associated with beta cell function. There was another study to just in support of that, which was published in 2014 in Diabetes Care, in which they have seen over the 6 months the effect of, they have compared the effect of exenatide, that is GLP-1 receptor analog, sitagliptin, that is DPP-4 inhibitor, and glimepiride on beta cell secretory capacity in early type 2 diabetes patients. So they have used arginine for insulin release. So they have seen 3 responses: acute insulin response, they have seen glucose potentiation, they have seen maximum arginine-induced insulin release. So what they have seen in the results is that change in glucose potentiation was significantly greater with glimepiride versus any other treatment, exenatide and sitagliptin. So if we see here 108, 80 and 119, so huge difference was seen. AI max was unchanged after 6 months of treatment with exenatide or sitagliptin compared with baseline, and it was increased with glimepiride. So to conclude from this study, after the 6 months of treatment, exenatide or sitagliptin had no significant effect on beta cell function mass as measured by beta cell secretory capacity, whereas glimepiride appeared to enhance the beta cell secretion. So no really functional capacity was not decreased if the glimepiride was used. So from these 2 studies, earlier we had a myth that glimepiride might cause beta cell failure. So current literature do not support that notion. On the contrary, sulfonyl appeared to improve beta cell secretory capacity when used early in the course of the type 2 diabetes. So we know that there is something called as ominous octet. We have been talking about it in, I think, almost all the talks. We have been reading about it for some time now. So ominous octet is there. So a single medication cannot really control diabetes, because increase in glucose levels, decrease in insulin levels, increase in glucagon levels, insulin resistance, a lot of things are happening, so that which ends up having which ends up leading to high blood glucose levels in the blood. So just giving one medication acting on one mechanism is not going to control the diabetes. So in fact, it is a misconception that sulfonylurea, it doesn't act on multiple mechanisms. It has just one mechanism, that it increases insulin release from the beta cells. But no, yes, that is the main function. There are other pleiotropic benefits, and moreover, when it is used in combination with metformin, the horizon of acting on multiple mechanisms is more. So if we see here, it has pleiotropic effects, the sulfonylureas. It helps in insulin clearance. It helps in glucagon, decreasing the glucagon secretion. It helps in insulin sensitization, decreasing insulin resistance. It does help in ischemic preconditioning, suppresses ventricular tachycardia, lowers BP. It has antioxidative mechanisms. It has anti-angiogenesis mechanism, and it helps in vascular health. So a lot of pleiotropic benefits are there, and it has been shown and it has been given in article published in 2015 in Indian Journal of Endocrinology of Metabolism. So multiple benefits of sulfonylureas have been seen. It is not only that, it is acting on one mechanism. So because it is because it is acting on multiple mechanisms, it is insulin secretagogue. So the efficacy is very, very high. So I think there is no doubt regarding that, and there's no controversy regarding that. Sulfonylureas are actually most efficacious oral medications available next to insulin therapy. So they decrease HbA1c of around 1.5 to 2%, so which is a good efficacy. So none of the other OHAs, DPP4 inhibitors, SGLT2 inhibitors leads to this high level of HbA1c reduction. Only sulfonylureas are the one. But yes, there is risk of hypoglycemia, but if you use it judicially, then the risk of hypoglycemia can be decreased markedly. Weight gain again is associated with the risk of hypoglycemia. If we are reducing the chances of hypoglycemia, the weight gain will also be less. Now we have studies to show that it is CV neutral. The risk of ASCVD doesn't increase, the risk of heart failure doesn't increase. Cost is a very important factor. So very cheap, very reasonable price, especially for us Indian patients. So we have to consider drug specific and patient factors when we are choosing any of the anti-hyperglycemic treatment. So there are a lot of myths associated with sulfonylurea, which we have been talking about, but these myths were mainly associated with conventional sulfonylureas. So we cannot blanketly say that, okay, if those sulfonylureas were bad, these are also going to be bad. Conventional sulfonylureas or first generation sulfonylureas were tolbutamide, glibenclamide, and glipizide. Now we do have available with us modern sulfonylureas, second and third generation sulfonylureas that include glimepiride, gliclazide, moderate release or extended release, glipizide, moderate release, and gliclazide, plain. So these conventional sulfonylureas, they were very strong. They used to bind on two receptors. The half-life was very prolonged. So the chances of the risk of hypoglycemia, weight gain, all those associated, the ischemic preconditioning and all these were, the risk was higher with conventional sulfonylurea. In fact, the misconception of that these are not CV safe, it came with these conventional sulfonylureas. So UGTP study was the first study where it was postulated that sulfonylureas might increase the cardiovascular risk, might lead to increased cardiovascular mortality. But in that study, the sulfonylurea used was tolbutamide. But now we have modern sulfonylureas. We do have enough data to show that these are quite CV safe, and that is what I'm going to show later in the slide as well. So as compared to these newer older sulfonylureas, including glimepiride, there is lesser weight gain, there is lesser risk of hypoglycemia. It augments both phase 1 and phase 2 insulin release, and they are in fact CV neutral, which I'm going to show later. So combination therapy, as I said, it reduces 1.5 to 2% of HbA1c target. So huge, quite efficacious medication. And when once used in a combination therapy, it is way much better than the monotherapy of metformin alone, because we know that HbA1c reduction efficacy is way much more with glimepiride as compared to a single monotherapy of metformin, and it has been shown in various studies. And I need not mention those studies. That there is no controversy regarding that. So there was these consensus recommendations published in Indian Journal of Endocrinology and Metabolism in 2018 by Dr. Kalra et al. So there they have said that modern sulfonylureas are effective and safe medications and can be used, and it is a grade 1 recommendation, grade A recommendation. It can be used in patients who are on metformin as a second-line therapy. It can be used even as a first-line combination therapy with metformin when the HbA1c is more than 7.5%. It can be used as a third-line medication when it is not being controlled on 2 medications. So I think in almost all the patients, sulfonylureas can be used very safely, and even the guidelines are there to recommend that. So I think I have been talking about efficacy a lot. So this is just another forest plot showing that the efficacy of glimepiride is way much more. It favors the glimepiride as compared to DPP-4 inhibitors. So the DPP-4 inhibitors, they reduce HbA1c by almost around 0.9 to 1%, not more than that. Glimepiride around 1.5 to 2%. HbA1c reduction is there. There is another recommendation that when patient is already on sulfonylurea and we need to put them on insulin. So what do we do? So in those kind of situations, yes, sulfonylureas can be continued, but yes, we have to be very, we have to take all the precautions so that patient should not go into hypoglycemia. If a premix insulin is used, then at that time we can use it in the meal in which we are using premix insulin. We can give the oral sulfonylurea in the antipodal meal, and if we are giving it twice daily premix, then in the middle, in the lunch time or in the third meal, we can give a short-acting sulfonylurea. So even modern sulfonylureas we have been using in our practice. Glimepiride, gliclazide we have been using. Even in the elderly patients, the risk of hypoglycemia is less if we are using it judiciously. We are asking them to monitor the dose, monitoring the glucose, as well as the regularly follow up with us. Now, a major important misconception which is associated with glimepiride is that the risk of cardiovascular disease is higher. So various studies to defy that misconception, one of which is published in 2008 in where they have seen patients who have developed CAD who were on glimepiride, and they were matched to the similar controls, and what they saw was that patients who were on glimepiride, gliclazide, or either, they had in fact low risk of CAD. The CAD risk was higher in patients who were on glibenclamide. That is the first generation or the conventional sulfonylurea or glipizide. So that is what we have been trying to say, that the newer sulfonylureas are safer than the older or the conventional sulfonylureas or the first generation sulfonylureas. So again, as I told earlier also, the risk of this CV, cardiovascular mortality or MI, it came in 1970 with the UGDP study, where they have seen that with the use of tolbutamide, there was increase in cardiovascular risk. So since then, there was always a talk about whether the sulfonylureas were safe or not. But we have been using sulfonylureas since then, since the second generation sulfonylureas have been marketed. So be it UKPDS study, be it advanced study, be it TOSCA-80 study where it was compared with pioglitazone, all these studies have repeatedly proven that sulfonylureas, especially the second generation sulfonylureas, are quite cardiovascular safe. But we did not really have a CVOT data. These are only basically glycemic efficacy trials which have proven that okay, there is improvement in the cardiovascular risk, but Recently, a CVOT data was published in 2019 by the name of Carolina trial, in which though they wanted to prove the safety of linagliptin, but they have compared it with the glimepiride. So in this trial, they have taken various degrees of patients who had established ASCVD, patients who have high risk for ASCVD, patients who are a long duration of diabetes, patients who have diabetes of less than 5 years of duration. So all kind of patients were taken in this study, and these basically it represents the garden variety of patients who are coming to our OPD. So they have taken on those patients and they have compared linagliptin 5 milligram per day to glimepiride 1 to 4 milligram per day. So what they have seen, they have followed up these people for around 6.3 years, and around 42% patients had established ASCVD, 37% patients had CV risk factors, 40% patients had diabetes for less than 5 years. All the patients are standard ecosprin, Storvas, the standard of care treatment for the cardiovascular disease. None were on the insulin. 9% were treatment naive, and around 80%, 85% were receiving metformin. So around 6,000 patients were taken in this, and this was the demographic profile of that study. The primary endpoint was 3-point MACE, that is CV death, non-fatal MI, non-fatal stroke. The secondary endpoints were 4-point MACE, and patients who were on treatment and maintaining HbA1c less than 7% at final visit without needing any rescue medication, without needing rescue medication, and the 2% weight gain. So looking at the primary, looking at the results here, the primary endpoint, that is the 3-point MACE, if we see here, for non-inferiority, the P value was significant. So it means that linagliptin and glimepiride both were similar in the cardiovascular risk, both were quite cardiovascular safe. And if we specifically see the cardiovascular death, then again there was an overlapping curve. The P value was not significant. Both were not inferior to each other. So last but may not be the least, long-term glycemic control is the essential to improve outcomes, cardiovascular outcomes, to renal outcomes, to microvascular diseases as well. This it has been there for last 70 to 80 years. Since then, we know that with a single reduction, with a 1% reduction in HbA1c, it helps in reducing the retinopathy, it helps in reducing the neuropathy, it helps in reducing the nephropathy. So 37% decrease in microvascular diseases, huge decrease in macrovascular disease like stroke, MI, heart failure, cataract extraction, and lower extremity amputation. So glimepiride is unsafe. That was a myth. We know that now. We have enough data to show that now, from especially of the Carolina trial, outcome was published in 2019. So after that, the cardiovascular safety of glimepiride is reassuring and may help the patients with type 2 diabetes world over to avail the benefit of these affordable, efficacious medication. So I think this was the most important myth, that glimepiride is unsafe. Glimepiride is unsafe. Probably that was the reason it was not being used. It is being used, but the use has decreased. It has come. The glimepiride has come to third line or fourth line medication after DPP4 or SGLT2. But no, we have data to show that. In fact, in few patients, in quite some patients, it is a good medication, especially in our Indian patients. And in fact, if we talk about the guidelines, multiple guidelines recommend the use of sulfonylureas as compared to any of the other antidiabetic medications. So ADA, IDF, ISPAD, all the guidelines, they do recommend the use of sulfonylurea, especially glimepiride and gliclazide, depending upon the target HbA1c, depending upon the current HbA1c and the medication they are already on. It can be used as a monotherapy. It can be used as a combination to metformin. It can be used as a third line medication, fourth line medication. And it is quite cardiovascular safe and can be given in elderly patients as well. So all the recommendations are there. So this, I think I have already told: monotherapy, second line medication, triples, combination therapy. So With insulin, yes, we have to be careful about the hypoglycemia. We can up titrate, down titrate the dose accordingly. In elderly also, we have to be careful. But if you're using it with caution, the risk of hypoglycemia is quite minimal. Even in Ramadan, it can be used very cautiously, and I have seen that patients, they do not, if you modify it to the short acting sulfonylureas, or if you modify the dose of the medications, if you guide the patient to fast according to the medications, their medications, then the risk of hypoglycemia is quite least. So coming to some practical tips, that the most important risk factor which we face using sulfonylurea is the risk of hypoglycemia. So the most important method to avoid this hypoglycemia is that we have to start low, step up slow. So we start according to the blood glucose value of the patient. We can start with 1 milligram of glimepiride or 2 milligram of glimepiride according to the RBS values or fasting values. And accordingly, we can ask the patient to self-monitor their blood glucose twice in a week or once in a week, and accordingly up titrate the dose every weekly. So it should be slowly up titrated. And timing, again, ideally it should be taken before the major meal of the day. Especially we do give it around before the breakfast. That is most of the times the major meal of the day. Adherence to medication as well as adherence to meal should be explained to the patient, because if a patient is taking the medication and a patient doesn't have their food, then the chances or the risk of hypoglycemia are very high. Then they should be educated regarding the need to carry diabetes identity cards, sick day management, recognition and management of hypoglycemia, and de-escalation of sulfonylurea doses once their glucose values are quite well controlled. So to conclude, clinical concerns associated with sulfonylureas are agent-specific. The earlier sulfonylureas, conventional sulfonylureas like tolbutamide, fluoride, glibenclamide, which we are not using these days, they do not really pertain to today's modern sulfonylureas like glimepiride and glitazide. Current theory is that the uncontrolled type 2 diabetes itself, not the sulfonylureas, cause beta cell failure. And very unique characteristics, especially in Indian patients, we need highly efficacious medications. We do have safety data for that. And hypoglycemia, if used cautiously, the risk of hypoglycemia is very less. Again, if hypoglycemia is less, the weight, it acts as a weight neutral, doesn't really need to weight gain. And the most important point, the sulfonylureas are quite affordable in the long run. And considering the affordability status of our Indian patients, they do form a very good option in our routine clinical practice, and it can help in controlling our diabetic patients better. So I think with this, I conclude my talk here.
Thank you, doctor, for that elaborate explanation. We have few quick questions. First is, where in your clinical practice would you place sulfonylurea today, considering we have different options, including SGLT2 inhibitors or DPP4 inhibitors?
Yes, we do have very good space, especially in Indian patients. So if a patient is already a long-term diabetic, the most of the patients who are coming to us in our routine OPDs, they are having diabetes for around 5 years or more or so. And most of them are already on 1 or 2 drugs of medications. If I expect them to be controlled only on metformin or only on metformin, DPP4 and SGLT2, it is very unlikely. So in those kind of people, in those kind of diabetic patients, yes, we have to give sulfonylureas or glimepiride. So in fact, if you ask me, around 80% of patients who are coming to our OPD, they will need sulfonylurea, they will need glimepiride. But if a patient is coming to me, a newly diagnosed diabetic patient, then a younger patient, and when I know that the HbA1c is around 7 or 7.5 or so, and a single drug or a single metformin and DPP4 or SGLT2 inhibitor will help in controlling the diabetes, then that would form my first option or a second line option. rather than glimepiride. But yes, when the HbA1c is very high, patient is not willing for insulin, even in a newly diagnosed, then we have to add upon a sulfonylureas. But patients who are requiring more than 2 drugs, patient who has a long-term diabetes, in those kind of patients, we do need to give sulfonylureas. Yes.
Yes, ma'am. Next is what are the challenges faced by the patient in actual clinical setting in terms of side effects like weight gain and hypoglycemia?
Weight gain is, I would say, if you really counsel the patient, we do not really see weight gain because of glimepiride or because of sulfonylurea. We do not really see. Yes, pioglitazone. Even patients come back and they complain that okay, I have gained weight after this medication. But with sulfonylureas, if you're using it very judiciously, no hypoglycemia is happening in between, then the chances of weight gain are not really high. Weight gain really happens when there are unidentified episodes of hypoglycemia happening in between and patient is snacking in between. So if you counsel well according to that, then the chances of having weight gain with sulfonylurea is minimal or is least. So I think practically I don't see much of weight gain with glimepiride, but yes, if you do not counsel well for the diet control, then if be on glimepiride, be not on glimepiride, patient will end up gaining weight. So that is there.
And lastly, ma'am, what is your final message to our audience today?
So just simple, one, I would say Indian patients are different. Our affordability status is different. Our glucose values are very high. Most of the patients who are coming once to me, they are coming back after 2 months or 3 months or 4 months. So those kind of patients, when we know that the glycemic control is so haywire, so these are very efficacious medications. These are very affordable medications, and 1% decrease in HbA1c if being with glimepiride, it can help in way much better terms than any of the other medications by reducing microvascular as well as the macrovascular complications. So glimepiride is a good molecule in that. Good affordability, good efficacy.
Thank you, Dr. Abhilasha Jain, for the enlightening answer and for the detailed explanation. In absence of further questions, I think we can end the session. So we thank you for your time and our audience for joining us.
Thank you so much. Thank you so much, Dr. Sharma. Thank you.
Thank you so much for your valuable time, ma'am. So from here now, I'm ending this meeting.
Thank you so much. Thank you.